Our project focuses on understanding how Wisconsin collects and manages mental health and behavioral health data across the state and why fragmentation across systems makes it difficult to coordinate care or measure outcomes. Working with the Mental Health Action Partnership, we looked at Wisconsin's current data environment, built a journey map of how people move through the system, and examined how other states have approached integration. Our goal is to identify realistic, actionable steps Wisconsin can take to improve data coordination. My name is Lydia Seay, and I am one of the presenters who will be talking about our project.
My name is Riley Schwietz. I will also be talking about this project. Wisconsin actually gathers a tremendous amount of mental health data, but also almost all of it sits in isolated systems. Each system captures important information, but they operate independently. Because these systems don't communicate, it's almost impossible to follow someone's mental health journey across touchpoints. That's the core policy challenge we're addressing. Each mental health, behavioral health, corrections, insurance, and governmental agency all maintain their own data sets. Each have their own identifiers, rules, and formats. No single system can show a full picture of an individual's experience. That makes it challenging to coordinate care, track outcomes, and identify where people are falling through the cracks. When we spoke with Tim Connor at their Institute for Research on Poverty, he explained that Wisconsin's fragmentation didn't happen by accident. They were created at different times with different funding and leadership, so they never developed common standards or a shared mission. Tim also noted that while technical integration is possible, the real barrier is agreeing on a single statewide vision for how an integrated data system should be used. That vision can't just combine the goals of the existing systems, it has to be a unified purpose everyone can commit to. His recommendation was to take an incremental approach, start with a small set of partners, demonstrate value, and allow other organizations to join as the benefits become clear. So why does disconnected data create such a significant challenge for Wisconsin? When information is spread across separate systems, it becomes very hard to understand whether services are working, coordinate care, or to measure outcomes in a consistent way. This lack of connection also hides important differences across race, income, age, and geography. Because the data isn't linked, inequities remain largely invisible, and people who repeatedly move through crisis care can't be identified early, because no single system captures their full experience. All of this raises an important question: who feels these gaps the most? Understanding the impact on specific groups helps clarify where improved coordination could make the biggest difference. When we look at who's most affected by these gaps, a few groups stand out clearly. Children and adolescents are especially vulnerable because they move between schools, crisis services, and outpatient programs, but their information doesn't move with them. That means early warning signs or patterns can be missed. Other groups include individuals who repeatedly cycle through crisis care, the justice system, and who experience other instabilities in their lives. These populations all interact with many different institutions or players in the system, yet none of these touchpoints connect in a way that gives providers a complete picture. These groups help illustrate why improving data connection matters. When the people most vulnerable to poor outcomes are also the ones most affected by fragmented information, the costs of inaction become even clearer. So we organized our work around 4 key deliverables, each giving us a different angle on Wisconsin's challenges. We started with the data landscape overview, which mapped the major systems collecting mental and behavioral health information and showed where data flows and where it breaks down. Next, the patient journey map shifted us to the lived experience, illustrating how fragmented data affects individuals moving through care. The comparative analysis then showed us how other states have addressed similar issues and what Wisconsin could learn from their progress. All of this informed our policy recommendations, which pulled together insights from each deliverable and offer realistic steps the state could take.
Hi, my name is Morgan Schillinger, and I'm going to be talking about the Wisconsin data landscape. The data landscape overview showed us how mental and behavioral health information is collected across Wisconsin and made clear that while there is plenty of data, the systems are not connected. Each data set serves a different purpose and follows different rules. Some track clinical care, others insurance claims, others community indicators. This revealed major gaps, including no shared identifier and limited ability to share information. We also saw that counties, hospitals, schools, and state agencies all maintain separate data sets without common standards. In the end, the challenge isn't to lack data, but the difficulty of using it to follow someone's journey through care. The data flow hierarchy helped us move from listing data sets to understanding how they actually relate. By mapping information pathways, we could see which systems function as central hubs and which remain isolated. This made it clear where integration is realistic, especially in systems that already share data with the state health department, and where it is much harder, such as schools, housing, and law enforcement data that sit under entirely different structures. Overall, the hierarchy showed us that the most promising integration points, the major bottlenecks, and where early efforts are most likely to succeed. When we pull out the statewide systems from the full data landscape, we see the core structure Wisconsin relies on for behavioral health monitoring. These systems offer the most consistent coverage because they were built for statewide reporting, payment, or surveillance. They include statewide service records, Medicaid claims, hospital and emergency department data, and payer-generated utilization data. Together, they form the closest thing Wisconsin has to a shared foundation. Seeing these systems as the backbone highlights where integration is most realistic. Where governance already exists, formats are standardized, and the legal framework is in place to begin linking data in a manageable way. Cross-sector systems capture parts of Wisconsin's behavioral health landscape that fall outside traditional healthcare, education, housing, justice, crisis contacts, and county dashboards. They follow different laws, funding streams, and reporting rules, and they capture early warning signs that never appear in medical data. Their fragmentation comes from governance, not technology. These systems are essential for a full picture of need, but they require long-term coordination rather than immediate integration. They highlight where Wisconsin's biggest information gaps originate and where policy alignment will eventually be needed. Looking across both statewide and cross-sector systems, the biggest takeaway is how many parts of Wisconsin's behavioral health environment still don't connect. Clinical records, county services, Medicaid claims, school data, crisis contacts, and housing information all operate separately, making it impossible to follow someone across settings. These gaps are where people fall through the cracks, hurting early identification, care transitions, and understanding what happens before or after a crisis. This is why our next step is the patient journey map, which shows where these disconnects appear in real time and where early integration would matter most.
My name is Emily Wu, and I will be talking about the patient journey map. So, as mentioned, our second deliverable is this map to make kind of sense of all this data. To navigate this, we were guided by the question, what could data integration do for a patient's journey? At the beginning of this process, we started with a systems map to identify the various stakeholders and relationships between them. Our map evolved from this to this to this. The more we learned from MHAP and our research, the more complex our map got. So we reorganized these relationships into a visual that shows how an individual moves through the behavioral health system. We named this deliverable the patient journey map and took a patient-centered approach. The patient is the one interacting with most or all stakeholders, and our impact population are the patients themselves. Through this map, though, we can also learn a lot about the stakeholders and systems as a whole. In these next few slides, you'll see us identify where data drop-offs and blind spots occur, visualize which touchpoints produce data and which do not, ultimately providing a framework for selecting realistic integration priorities. To start, we mapped out what the current landscape looks like for a patient undergoing a mental health crisis. Each icon represents a player in the system, and the gray lines represent a transfer of data. Some things to note in these visuals are the amount of smaller branches. Patient data is difficult to share and requires a caseworker or institution staff to initiate some type of transfer. This can cause delays and sometimes even missing information as represented by the dashed lines. And sometimes, as we see from the red patient icon, the patient or family becomes the person who is reaching out to access or relay information between providers. Another thing you might notice are the red stars throughout the slides. Each star indicates whether or when there is an additional copy of a patient file created. These stars multiply quickly throughout the stages, which can make critical information less accessible. These copies contribute to a mass overload not only for the case managers, players, and patients themselves, but on a technical level, also the data system. The more we can simplify this, the better chance we have to develop a robust and safe system. Looking at the initial map, here are some of our findings. There's a lot of fragmentation in the system. No single data set follows a person end to end, and there are many moments in the journey spent on reaching out to institutions to retrieve data. Much like our research and need to create an aggregate list in deliverable one, there are immense barriers to transferring data efficiently and securely. Secondly, there are multiple data gaps throughout the journey, especially as we're transitioning from crisis to inpatient to outpatient stages. This occurs due to lack of shared identifiers and inconsistent reporting of detentions and holds. On a broader scale, counties vary widely in what they track and how. As future PAs, policy analysts, healthcare workers, and advocates ourselves, it's important that the providers and players see the potential between stages in the system. And all of this leads to looking at downstream responsibility, how the burden starts to fall on the patient or family to seek out resources, manage insurance, and initiate data transfers between institutions. We want to work towards a system where providers and case managers are sufficiently supported to be the patient's advocate. So despite all these challenges, this map is helpful in increasing visibility for high-value integration points. From here, we looked at state-specific policies that would fit into each stage. Some policies may also work across multiple stages. We'll discuss these more in depth in our next section that goes hand in hand with this part of the journey map. Some things to note are these central green icons representing unified databases or interoperable systems from other states. There are also areas where we've identified parallels to existing systems or infrastructure in Wisconsin that are also noted by the green icons. As we work toward our proposed changes in the system, we wanted to add a note on how our ideal journey progresses. Currently, we start the patient journey at an emergent episode and loop back during a relapse or another crisis event. However, we realized that we were approaching this through the perspective of medical conditions that are acute, temporary, or have clear and defined treatment protocols, like a broken bone, a concussion, or even a chronic condition like asthma. When we think about mental health, it's not something that just comes and goes as a condition. To revisit our working definitions, mental health refers to a state of well-being, something that in medical terms is chronic and in lived experience, lifelong. So we shifted the sequence for our ideal state. Instead of a crisis, we're renaming this a person's journey and setting stage one as the everyone stakeholders, natural touch points where we regularly and naturally interact with on a daily basis. For children and adolescents, this could be a pediatrician, school counseling and peer services, or community activities. Being specific and intentional about our language and perspective is important, not only as we humanize mental health, but also as we consider how early intervention has a lasting impact on development down the line. Rather than solely focusing on policy that is reactive, we also want to look at preventative care. Overall, these maps were really helpful to visualize this complex landscape, but we hope it can also be useful to members of MHAP or policymakers without feeling too overwhelmed. We recognize that MHAP is made up of a diverse group of experts from various fields and disciplines, so we hope this breakdown of stages is also helpful as a pivot point to go more in depth in any direction. These also help us identify which stage is the best candidate for a pilot or phase rollout. Our comparative analysis looked toward cross-state models where pieces or multiple policies could be combined or adopted. Finally, these partner deliverables grounds the analysis in Wisconsin realities, looking towards a realistic and feasible way for us to implement these proposals.
Starting with California, we see that they currently have a mandatory data exchange framework that features a unified data sharing agreement. This agreement allows there to be a secure, real-time exchange of data between healthcare and social services entities throughout California. In addition to the data sharing agreement, they have Senate Bill 929, which amends California's Code for Institutions and Welfare. It requires the Department of California Health Services to extend data collection and reporting for individuals who are subject to the Lanterman-Petrish Short Act regarding involuntary holds, conservatorships, transfers between mental health facilities, and the outcomes from these occurrences. One of the strengths is the improved consistency and statewide transparency regarding patient data and outcomes. This allows policy to be properly informed and a full range of information to be shared. A major weakness is that the administrative workload regarding the amount of what needs to be reported, who will be over this integration and reporting, and how this information will be cataloged needs to be considered.
Next, we took a look at the New York Psyche's Claims Viewer. This is a platform that builds on Medicaid claims to create a secure, web-based tool that shows treatment histories, medications, and behavioral health incidents. Since it draws on administrative data rather than direct electronic health record feeds, it demonstrates how Wisconsin could give clinicians and county staff a unified, Medicaid-centered view of care histories. Linking WHIO and PPS data could replicate this care coordination. Significant strength of this model is its ability to allow for continuity of care and outpatient coordinations. Unfortunately, it is restricted by 42 CFR Part 2, which is a federal regulation that protects the confidentiality of substance use patient records.
Moving on to Indiana and Washington and their analytic hubs, Management Performance Hub, and integrated client databases. Both states have implemented centralized cross-agency evaluation platforms that include data from Medicaid, behavioral health, justice/corrections, and other stakeholders to aggregate and evaluate patient data. A major strength of the Analytic Hub is a strong multi-system analysis of the aggregate data and the implications and outcomes the data presents. A weakness is that there is a high pressure of governance amongst participating agencies and large technical needs for creating and maintaining the Analytic Hubs.
This next model is a partnership of New York, Texas, Louisiana, Oregon, and Illinois. They're all part of the National Academy for State Health Policy, and we focused on their Medicaid housing systems. These are aligned by matching homeless management information system data with Medicaid claims. By replicating this approach, Wisconsin would identify high-risk populations and fund supportive housing interventions through Medicaid managed care contracts. There is adequate evidence that this integration can improve stability and mental health outcomes for those most at risk due to housing instability. Again, there are significant privacy complexities associated with this model. It is also important to recognize that this model must be used only for service coordination, not surveillance, as this linking may unintentionally criminalize poverty if used for eligibility enforcement rather than supportive services.
Now, as we move on to cross-state themes, we see 4 successful features found in the models. The first of which being starting with a narrow, achievable pilot. We propose an initial focus on children/youth mental health or county-based pilots. Secondly, we find the importance and success of building governance before technology. Understanding and having a clear scope is necessary. Third, we see the success of relying on existing administrative data. It builds off of achievable pilots, and current and previous data is already accessible and can be used to further categorize and pilot data integration. And lastly, we see the success of anchoring integration in Medicaid data sets. Data that is accessible and are already aggregated will be easier to integrate. What this means for Wisconsin. We see that Wisconsin's strongest leverage point is mid-journey data, which includes claims and county outpatient. Another example of a small pilot would be starting at the county level. So with Dane County, Milwaukee County, and other counties where a large amount of population and data would be present and available. And we see the journey map helps to isolate feasible starting points. Our first policy recommendation is adopting a single standardized data sharing agreement. This recommendation moves towards one unified data sharing agreement across behavioral health, medical care, and social services. It aims to simplify consent, clarify privacy expectations, and create a consistent statewide framework for linking and protecting data. There are very real trade-offs. Building an agreement will require long negotiations with counties, providers, and private data holders, and some may be wary of increased state oversight. Aligning different privacy rules will also take significant legal work. Equity is central. If not designed carefully, a single agreement could increase monitoring of marginalized groups. So it is important to have strong consent protections, clear limits on data use, and input from affected communities are essential.
Our second policy recommendation is to build a central behavioral health analytics hub. This proposal creates a cross-agency analytics hub in the state health department to bring together behavioral health, Medicaid claims, and exchange data for stronger evaluation and outcome tracking. The trade-offs include major technology and staffing investments added security and privacy risks, and potential hesitation from agencies about sharing sensitive data. There are equity risks as well. Without careful interpretation and oversight, integrated data could stigmatize certain populations, so built-in equity reviews would be essential.
Our third policy recommendation is implementing a psyche-style clinician portal. This recommendation creates a secure clinical viewer that pulls existing claims and program data, giving clinicians and county staff a clearer picture of treatment history to support better decisions at the point of care. The trade-offs include strict privacy requirements, especially for behavioral health and substance use data, and the technical and training demands of integrating the viewer with existing medical records. Equity risks also matter here. More information could lead to overinterpretation or stigma, so strong consent controls, limits on sensitive fields, and provider training are essential.
Our fourth recommendation is mandating standardized reporting of involuntary holds. This recommendation would require counties and hospitals to report all psychiatric holds, transfers, and outcomes to the state. Closing major gaps in crisis care monitoring and allowing consistent statewide tracking. We do recognize that this may increase workload for counties and hospitals, many of which already face staff shortage and limited data capacity. There is also the challenge of creating standardized definitions and the procedures across jurisdictions, particularly distinguishing between voluntary and involuntary episodes or overlapping medical holds. This could be especially difficult without additional funding, training, or technical support. Additionally, there is high risk if this mass transfer of data is mishandled. Mandatory reporting could deepen mistrust among communities that have historically and disproportionately been subjected to psychiatric holds, particularly Black men, Indigenous individuals, and LGBTQ+ youth. If these data are not de-identified or are used for enforcement rather than quality care improvement, it has a lot of potential to reinforce systemic inequities. To prevent harm, reporting should focus on aggregate outcomes and not individual surveillance, and include civil rights oversight and data interpretation.
Our fifth policy recommendation creates a public dashboard that reports county-level behavioral health trends to increase transparency and support local planning. The trade-offs here include re-identification risks for small counties and the possibility that public metrics could be misunderstood or politicized, requiring clear communication and strong suppression rules. Equity risks are also present here, as public data can unintentionally expose sensitive patterns. So community review boards, protective thresholds, and plain language context would be helpful.
Lastly, our sixth policy recommendation is to integrate housing and social determinant data through Medicaid. This recommendation links housing data with Medicaid claims to identify people at risk of instability and better support housing-related services. The trade-offs include complex agreements, new privacy protections, and Medicaid limits on what housing services can be reimbursed. The equity risks are also real here. Linked data could be used for monitoring instead of support, so strong safeguards and community oversight are essential.
So what comes next? Overall, our analysis shows that Wisconsin can make meaningful progress by taking targeted, practical steps rather than attempting a full system overhaul. Other states succeeded by building governance first and starting with focused pilots, and Wisconsin can do the same. A pilot, clear standards, and a phased approach using existing data offer a realistic path that addresses core challenges while laying the groundwork for long-term integration. Most importantly, this approach can improve outcomes for people most affected by current gaps, making care more connected and reducing inequities. The pieces are already in place. What's needed now is a clear starting point and steady movement toward a more coordinated system. Thank you for listening.